Thank you, Professor Moti and ISCH, for the kind invitation to present on follicular lymphoma. I'm Nilanjan Ghosh. I'm a lymphoma researcher and hematologist at Levine Cancer Institute in Charlotte, North Carolina, and also at the Wake Forest School of Medicine. And the topic of my discussion today is state-of-the-art management of follicular lymphoma. So just to introduce follicular lymphoma a little bit, it's a disease with an indolent biology, but it can sometimes transform into an aggressive B-cell lymphoma. The age of onset is typically in the sixth decade, but about a quarter of patients are under age of 40. The prognosis, there are numerous prognostic tools, but they lack accuracy in identifying inferior outcomes at baseline, and I might say perhaps also in identifying those who would have excellent outcomes at baseline. And therefore, unfortunately, prognosis is often defined by event-based outcomes. So if someone does poorly within 2 years after treatment, they're considered in this group called POD24. What we really want is a way to identify them at baseline rather than having an event-based prognostic tool. And then in terms of treatment, there are numerous treatments available, but we don't have very good sequencing data. And there's certainly a paradigm shift from chemotherapy to immunotherapy, and hopefully I'll be able to convince you that through the presentation. And then in terms of outcomes, most patients have favorable outcomes. However, patients who progress within 24 months in this POD24 group have inferior survival. So let's start with prognostic index. And yeah, how good are we with predicting outcomes? So in this AI generated image, what you see is there are a number of different tools available, but what you really want is the crystal ball in the center, which will be able to predict who's going to do really well and who's going to not do well. And therefore you can cater your treatments accordingly and expectations, but we unfortunately don't have that. There are a number of prognostic indices available in follicular lymphoma, as is shown on the slide. I don't mean to go through all the details, but I've shown you a timeline over here, starting with the IPI, which is mainly done for aggressive B-cell lymphoma, but in follicular lymphoma, it has poor discrimination between lower intermediate and high intermediate risk. What you want to see in these prognostic indices is a good discrimination between low risk, high risk, and intermediate risk. Even when you look at things like FLIPI-2, FLIPI was also done in the pre-rituximab era. FLIPI-2 did include patients who had rituximab. About 60% of patients, including FLIPI-2, had rituximab. And you can see that between intermediate risk and high risk, it's 88% versus 77% 5-year overall survival. So you really want to have better discrimination. Prima PI is also a good prognostic tool, but still has some limitations. You can see low intermediate risk versus high risk is again just 93 versus 81% in terms of 5-year overall survival. And then M7 FLIPI, which came in 2015, tried to incorporate mutational data from a number of 7 genes into this, but the limitations have been that it's not easy to get this data done in a routine practice. And then even after doing that, it's still not very good in determining who are going to be very high risk versus those who are at do not belong in that category. So these are the limitations, but at least we do have a number of prognostic indices. What we know that in follicular lymphoma, there are multiple clones at diagnosis, and there's some low frequency clones which often contribute to therapy resistance and transformation. And these may not appear in the routine genetic and molecular studies. And over time, these might, grow out and cause resistance and, cause, inferior outcomes. At present, none of these indices, serve as predictive biomarkers for a precision medicine approach to therapy. However, we do know that patients who progress early have inferior outcomes. So in this, in this graph, what you see is patients who had no progression, they seem to do obviously better, and that's intuitive. Of course, if somebody does not progress, they're going to do better. But those who had early progression, their overall survival is also inferior, meaning that subsequent therapies are not able to rescue those patients as good as they would if those who did not progress early. So with every section, I'm going to try to present the data, but then also show, the future. So FLIPI-24 is an improved international prognostic model to predict POD24. So this is up and coming. It has been presented. It does take into age, LDH, beta 2 microglobulin, hemoglobin, and WBC count. So all very easy clinical and laboratory parameters, and it is predictive of early progression and overall survival. It has better discrimination compared to the other prognostic indices. So as you can see, the curves are nicely separated out. I think it can still do better, but and there is an online calculator available. So I just wanted to highlight this FLIPI-24 as one step in the forward direction. Future directions for prognostic markers. Can we identify a group of patients who will progress quickly with standard treatments? And if we can do that, then we could consider treatment with clinical trials, including bispecific antibodies or CAR T earlier. And then can we also identify a group of patients who will do extremely well with any of the standard treatments? And that would be someone who we would be focused more towards less intervention and focus on low risk interventions, because no point in pounding very hard if they have good disease biology. So what we really want to know is, instead of an event-based outcome where we only after the event of progression happens, we find out, oh, it was bad disease biology. We want to understand at baseline who has good disease biology, who has poor disease biology, and then be able to cater treatments according to that. So hopefully that will be in the future. So now moving on to the next part of the talk, which will be frontline treatment, and we'll discuss low tumor burden first, followed by high tumor burden later. And again, I have an AI-generated image over here, which shows W and W, which I can say wait and watch, or you can think of wait and worry. So you can decide that this person is just watching or worrying about the follicular lymphoma. And the other option is rituximab, where there is an active intervention. So I'll highlight a few studies which will talk about rituximab in the front line, and this one actually compared rituximab with wait and watch. So this was again a large study which took patients with asymptomatic low tumor burden follicular lymphoma and randomized patients into watchful waiting, rituximab for 4 doses, which was closed early, and then rituximab for 4 doses followed by a 2-year maintenance every 8 weeks. So the primary endpoint was time to next therapy in this study. And what you can see over here is patients who are in the rituximab arm had a much longer time to start new treatment compared to those who were in the active surveillance or waitful watching arm. And there was, when they compared rituximab maintenance versus rituximab alone, there was no difference to time to next therapy, overall survival, or histologic transformation. But those who had, when you look at progression-free survival, there was an advantage with rituximab maintenance compared to no rituximab maintenance. And then came the resort study, was also, has been published and studied. So again, same treatment population. Here, the idea was to give everybody 4 doses of rituximab. And then if they responded, they could go into RR, which was rituximab retreatment, or MR, which was rituximab maintenance, so maintenance rituximab. So retreatment was they would just wait until progression and then retreat it with rituximab, versus they got maintenance. So when you now look at long-term data with this study, and this is 10-year data, and when you look at freedom from first cytotoxic therapy, those who received maintenance rituximab had higher freedom from first cytotoxic therapy compared to rituximab retreatment. But at 10 years, duration of response, as you can see in the first curve over here, 66% with maintenance rituximab and 30% with retreatment with rituximab. Overall survival was similar in both. And then one more study I want to highlight is, so we saw that rituximab maintenance does have some benefits. So what about short maintenance versus long maintenance? So this was the SAC study where they compared patients who got short course of rituximab maintenance, 4 maintenance doses after the initial 4 weekly doses compared to long maintenance for 5 years. And again, what you see over here is uh, 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 there is really no difference between a short maintenance and a long maintenance. So which has implications, no difference in PFS and no difference in overall survival. So there are some downsides of long maintenance with rituximab, and we've learned this in the COVID era even more than what we knew of before. And that is increased risk of infections, increased time commitment for patients, especially in low tumor burden disease where patients are not symptomatic, and to commit them to a prolonged treatment is sometimes difficult. And then there is also no benefit with time to treatment failure on the result data. And of course, there's increased cost as well. Therefore, a short rituximab maintenance course may be more acceptable. So this leads to the LYSA study, which was recently published in the JCO, which was a really nice, randomized trial comparing IV rituximab 4 doses versus subcutaneous rituximab with short maintenance. And this is the outline of the study shown over here, and a progression-free survival was the primary endpoint. And what you can see is there is a significant improvement in progression-free survival with subcutaneous rituximab 8 doses versus IV rituximab 4 doses. And about 58% patients were progression-free at 4 years with the subcutaneous rituximab arm versus 41% in the IV rituximab arm. And that same also in other secondary endpoints in terms of complete response was much higher in the subcutaneous arm. Understandable, there were more doses in that arm as well. But I just wanted to highlight really good outcomes. So I think this could be a very good standard option for patients where they are getting the benefit of maintenance, but they're also not being subjected to long maintenance. And, so they get 4 weekly doses followed by 4 additional maintenance doses. So again, like I said, that every section we're going to talk about future directions. So this is a study which I'll be leading and expect to activate shortly this summer. This is a large randomized phase 3 study in follicular lymphoma, low tumor burden, S2308. It will be open through the cooperative groups. And patients will get randomized to rituximab subcut, very similar to what was done in the LYSA study. And now this being a control arm, and then trying to move immunotherapy up front with bispecific antibodies and using mosunetuzumab for 8 cycles in the experimental arm, and stratifying patients by FLIPI as well as prior radiation exposure or not, and then age. So we'll see, whether a bispecific antibody added in frontline in patients who have not had any exposure to chemotherapy before, if they can, somehow improve on the outcomes from rituximab, which are already quite good, but maybe we can even aim for a cure with follicular lymphoma by incorporating this immunotherapy in low tumor burden patients in the frontline setting. So now moving on to high tumor burden patients, and the goal with high tumor burden patients, of course, we have to treat, but how can we maximize efficacy and minimize toxicity in this patient population? So let's look at some options over here. We are very aware of the excellent results from the PRIMA study, which have been updated recently, and we have 10-year data as well. So PRIMA study was patients with follicular lymphoma in the frontline setting who met GELF criteria, and they received R-CHOPs. They were randomized into maintenance rituximab versus no maintenance rituximab, and this was 2 years of maintenance rituximab. So you can see that there was a significant difference in the median PFS when maintenance rituximab was added, and at 10 years, 51% versus 35%. The median was significantly different, 10.5 years versus 4.1 years. There's still no difference in overall survival. What about bendamustine rituximab and comparison of that with R-CHOP? So there have been two large studies which have been published. I'll just quickly go over those. First is the STILL study published by Rummel and colleagues from Germany. And this was BR versus R-CHOP. And this showed an improvement in progression-free survival and fewer toxicities with BR compared to R-CHOP. However, a US study called the BRIGHT study, the difference was very muted between bendamustine rituximab and R-CHOP. The toxicities were also different, really, between BR and R-CHOP. So the STILL study did not have any rituximab maintenance. The BRIGHT study, about 45% patients received rituximab maintenance. What about obinutuzumab? So that's the other CD20 antibody which came after rituximab. And there was a large study called the Gallium study, which looked at rituximab-based immunochemotherapy versus obinutuzumab-based immunochemotherapy, about 1,200 patients, 600 randomized in each arm. And patients who got rituximab-based chemoimmuno received rituximab maintenance, and those who got obinutuzumab-based, they got obinutuzumab maintenance. So we have long-term follow-up from this study as well. And after about 8 years of follow-up, it was shown that obinutuzumab-based chemoimmunotherapy followed by obina maintenance had an improved progression-free survival compared to rituximab-based. And so this one, also showed that there were side effect profile was different. There was some increased side effects, at least numerically, in obinutuzumab arm compared to the rituximab arm. As you can see, infusion-related side effects and some serious adverse events. When you look at the progression-free survival, 7-year PFS rate, 63% with obinutuzumab-based treatment versus 55%, just statistically significant. Now, moving on from chemoimmunotherapy to immunomodulatory drugs like lenalidomide. So this is the relevance study, which compared a chemoimmunotherapy approach compared to lenalidomide or IMiD-based approach. And you can see over here, this is a large randomized study again. And both groups, after they finished the initial part, they were able to get maintenance rituximab. And the outcome at 6 years was no different, both for PFS as well as OS. So, this actually was a bold attempt to incorporate immunomodulatory drugs in the front line, and it led to similar outcomes as chemoimmunotherapy. So if rituximab plus lenalidomide had good outcomes similar to chemoimmunotherapy, what about obinutuzumab? This is not a randomized study, but what you can see over here in this very important study is that obinutuzumab combined with lenalidomide, there's an induction phase and a maintenance phase. And the outcomes are excellent. As you can see over here, overall response rates are in the mid-90s. The complete response rate by Lugano criteria is 80%. At a median follow-up of 3.7 years, the 3-year PFS is 82%. So the median was not reached. So again, the Gallen study, which was obinutuzumab plus lenalidomide, again showed very good outcomes when you add obinutuzumab to lenalidomide. So many different treatment options in this high tumor burden population. But let's just take a step back and think like how we can figure out what treatment to use. So this is a very good retrospective study from MD Anderson by Paulo Strati, published in Hematologica a few years ago, looking at the baseline PET CT scan and trying to figure out how the outcomes were different treatments were, depending on the SUV max on the baseline PET CT scan. So what you see is for patients, and these patients could have got R-CHOP, they could have got R-bendamustine or lenalidomide plus rituximab, and some fludarabine-based regimens, and some patients got rituximab alone. So when patients got R-CHOP, irrespective of whether they had a high activity on the PET scan versus a low activity on the baseline PET scan, there were no differences in outcomes. So R-CHOP was able to take care of both. However, when you now look at the others, which include bendamustine, lenalidomide, FND, and single-agent rituximab, they did quite well, just similar to R-CHOP, if they had low SUVs, or I wouldn't say very low, but at least less than SUV 18. But if they had very high activity at baseline, then the outcomes were poor, and that is shown in the figure as well. So I think what this tells us is, if somebody has a high activity and the biopsy still shows low-grade follicular lymphoma, maybe leaning more towards R-CHOP would be a good idea, and you can extrapolate that. And if you wanted to incorporate obinutuzumab-based regimens in that, that would be okay. But if they didn't have very high activities, then going with the others might be just fine. So I think that is at least helping us a little bit in terms of trying to figure out what to use. The other thing to remember sometimes is for patients who have high SUV activity or high activity on the PET scans, they might have a transformed disease as well. So if that lesion is not biopsied and another low activity lesion is biopsied, you may miss the transformation. And we know that if there's transformed aggressive disease, anthracycline-based chemotherapies are superior in that scenario. So just that. And again, now that we are coming to a close with the frontline treatment, I'd like to point out a future direction for high tumor burden follicular lymphoma. Again, going back to the original theme that immunotherapy is really coming in a big way in follicular lymphoma in earlier lines of therapy. So these two studies aim at incorporating bispecific antibodies in frontline follicular lymphoma in high tumor burden. I already showed you in the low tumor burden setting a similar concept. So here, looking at odronextamab, which is again a CD20, CD3 bispecific antibody, the first phase of this study, of this Olympia study, is single arm, and then it goes into a randomized phase where you compare odronextamab followed by odronextamab maintenance to standard of care treatment options. And then another similar study using a different bispecific antibody, epcoritamab, this time epcoritamab in combination with rituximab plus lenalidomide, compared to rituximab, lenalidomide, or rituximab or obinutuzumab chemotherapy backbones. So again, trying to improve on these outcomes by incorporating bispecific antibodies in the frontline setting. So conclusions for the frontline management of follicular lymphoma: low tumor burden disease options could be wait and watch or wait and worry, however you want to think about it, versus rituximab plus minus maintenance. I would argue that the short maintenance on the recently published LYSA study sets a really good balance between no maintenance and long maintenance. And in high tumor burden symptomatic disease, initial step is to rule out transformation with PET-directed biopsy. Treatment options include backbones such as CHOP, bendamustine, or lenalidomide. Add in a CD20 antibody like rituximab or obinutuzumab, with the note that obinutuzumab offers better progression-free survival than rituximab, but has higher toxicity, slightly higher toxicity in terms of infusion reactions and some other serious adverse events. And then CHOP is preferable for patients with high SUV lesions on a PET scan. There's significant PFS advantage with rituximab maintenance if R-CHOP is used as the backbone, as was shown in the PRIMA study. And then the emerging treatments are bispecific antibodies are being explored in clinical trials in frontline management of both low tumor burden as well as high tumor burden patients. So now let's move on to treatment of relapsed refractory follicular lymphoma, where there are, again, many options, and you have to choose which one to use and how do you sequence them. So again, there's an AI-generated image over here, which someone is just trying to figure out which option they're going to choose. So let's look at a little bit in terms of going back to that POD24 question. About 20% of patients who get frontline immunochemotherapy will progress early. And as I showed you previously, their outcomes are much inferior in terms of overall survival compared to the non-POD24 patients. When you look at relapsed follicular lymphoma, You can think of second line as well as then third line and beyond. So in second line, because of this early relapse versus late relapse, I think there are a few questions which should come to mind when you're trying to decide. And the first question is this an early relapse or a late relapse? Second is this low tumor burden? And third, is the patient frail? So if it's none of these, then the next question is this person previously exposed to prior immunochemotherapy? If no, then immunochemotherapy is a good option, but also rituximab or obinutuzumab plus lenalidomide is a good option. Follow and then consider maintenance. If the answer is yes, that they have been exposed to immunochemotherapy, then consider lenalidomide or with rituximab or obinutuzumab because they've not received that. Or you can repeat the chemoimmunotherapy with a different backbone. So if somebody got bendamustine, they could get CHOP. If someone got CHOP, they could get bendamustine and again consider maintenance. However, if the answer to the initial question was that if there is a late relapse or if there is low tumor burden and if the patient is frail, then watchful waiting, rituximab single agent, radiation therapy, if localized, or clinical trial can be done. And again, always rule out histologic transformation with new biopsy. And then for third line or beyond, there are many options. So there's bispecific antibody, CD20, CD3 bispecific antibody. Mosunetuzumab is approved in the third line and beyond. BTK inhibitor, zanubrutinib plus obinutuzumab, data from the Rosewood study was recently published and again approved. CAR T cell therapy with axi-cell, T-cell, or lysocell. EZH2 inhibitors such as tazemetostat, IMiDs, immunomodulatory drugs, lenalidomide-based combinations with obinutuzumab or rituximab, monoclonal antibodies, rituximab or obinutuzumab, chemoimmunotherapies, as we discussed, and then stem cell transplant consolidation is another option, and radiation for localized disease or palliation. So many, many options, certainly in the relapsed refractory follicular lymphoma. One study which is nearing completion is the S1608 study, which took patients who had early progressive disease, so POD24, with follicular lymphoma, and they were randomized initially to get umbralisib plus obinutuzumab. Umbralisib was a PI3 kinase delta inhibitor. This is not available anymore, so this arm is closed. Lenalidomide plus obinutuzumab, CHOP or bendamustine plus obinutuzumab, and the decision for CHOP or bendamustine was based on whatever they received frontline. If someone received benda, they could have received CHOP then, or someone received CHOP, then they could receive bendamustine. So we'll see as the study reports its outcomes in the near future, what would be a good second-line treatment option for patients who relapse early or in that high-risk POD24 group. This study was done prior to results of the when it started accruing. Bispecific antibodies had not yet been available, so it doesn't have incorporation of bispecific antibodies, but that would be another group of patients where bispecific antibodies might be very beneficial. So now, let's look at some of the trials which have been published in the relapsed refractory setting. Lenalidomide plus CD20 antibodies. I showed the data in the frontline setting, which is from the relevant study. But now let's look at data in the Augment study, which was in the relapsed refractory setting. This compared rituximab lenalidomide to rituximab alone, and these patients were not rituximab resistant in order to be eligible, since patients did receive rituximab in this study. And so you can see a significant improvement in the progression-free survival, 27.6 months with rituximab plus lenalidomide compared to just over a year with rituximab, and significant improvement in time to next therapy. And there was also overall survival. This was recently, a couple of years ago, presented, and there seemed to be an overall survival benefit. You can see that has a ratio of 0.59 with a confidence interval less than 1 and a p-value of 0.02. And then, so what about lenalidomide plus obinutuzumab? This is a single-arm study, and it showed again about a third of the patients are free of progression at 2 years, And at 2 years, the majority of patients are alive. 87% of patients are alive at 2 years. So again, very good outcomes of rituximab or rituximab or obinutuzumab plus lenalidomide. And then when we look at BTK inhibitors, so the Rosewood study, which compared zanubrutinib, the BTK inhibitor, plus obinutuzumab, compared to obinutuzumab alone. And I wanted to highlight from the baseline characteristics that the median prior number of therapies was 3 in both the arms. And in terms of POD24, the high-risk group, about a third of the patients in the zanubrutinib obinutuzumab had POD24, about 42% in the obinutuzumab arm. So you can see a significant difference in the PFS when zanubrutinib was added to obinutuzumab, a median PFS of 28 months compared to less than a year for obinutuzumab. There were some side effects which were numerically higher when you added zanubrutinib, and those were thrombocytopenia and pneumonia. And then there were others like neutropenia and anemia, which were similar. So again, another treatment option for patients with relapsed refractory follicular lymphoma with BTK inhibitor. And we know that previously BTK inhibitors have not been very effective, especially ibrutinib and other, when it was tested, but zanubrutinib does seem to have activity in this randomized study in relapsed refractory follicular lymphoma. Now moving along to bispecific antibodies. And so this is, a single-arm study in relapsed refractory follicular lymphoma. We have mature data from the study. Bispecific antibodies are typically always started in the cycle 1 with a ramp up to lower cytokine release syndrome. And so, as you can see on this study, we're using IV mosunetuzumab, a low dose of 1 milligram, followed by 2 milligram, followed by 60, and then 60 milligrams in cycle 2 as well, and then de-escalate to 30 milligrams. Mosunetuzumab is a time-limited treatment, so patients receive either 8 cycles if they get a complete response, and they can stop. If they get partial response or stable disease, they go up to 17 cycles, so 1 year of treatment every 3 weeks. So what you see over here in some updated data presented at ASH recently, that those patients who got a complete response had a very long duration of response. If they got a partial response, they did not. And the progression-free survival, 24 months with mosunetuzumab in this heavily pretreated population. Side effects, we've heard of CRS from CAR T-cell therapy. CRS does happen with bispecific antibodies as well, although it's not the same. The number of CRS events are much lower with bispecific antibodies, and also the grade of CRS is typically lower. So what you see with mosunetuzumab, 44% incidence of CRS, and many of them were just a fever. And we know that fevers can happen from antibodies. So 26% grade 1 CRS, grade 2 CRS, which can include hypotension, and it was seen in 17%, and very rare for grade 3 or grade 4 CRS. You can also see, according to that, is that the utilization of tocilizumab and corticosteroids is not very common for the management of these. Many times, antipyretics may be enough. But of course, there are patients who may need corticosteroids and tocilizumab. In this study, 11% patients needed corticosteroids, and 8% patients needed tocilizumab for the management of CRS. And all CRS events were resolved, so 100% resolution of CRS events. Another important thing to remember, that the CRS typically happens early on, so in cycle 1 or perhaps the beginning of cycle 2, but after that, typically the CRS doesn't happen, as shown in the second figure. So, and the other thing to remember with bispecific antibodies is the neurologic toxicity is extremely low, unlike CAR T, where that can be higher. So now what about epcoritamab? This is another bispecific antibody, CD20, CD3. Trial design is different. Frequency is also different. This is treatment till progression. I just showed you mosunetuzumab, which was, either 8 or 17 cycles. Here it's treatment to progression, and what you can see is up to the first 12 weeks, it's weekly, then after that every 2 weeks up to 36, and after that every 4 weeks. So again, overall response was the determining endpoint. And then these patients also received a ramp up to mitigate CRS. So efficacy and toxicity are shown over here across the various subgroups. Efficacy was high, the response rates were really high. As you can see, the complete response rates in the different subgroups have been the lowest one was patients who were refractory to last prior therapy, but high response rates overall. Complete response was also associated with favorable long-term outcomes. I showed you similar data with mosunetuzumab. So here we can infer from this that if someone is getting a complete response, then they're likely going to have also a sustained response versus those who get a partial response, they may progress early. And then when you look at safety profile, again, we shouldn't really compare across trials, but numerically, CRS incidence was a little bit higher over here, but again, most of that was low grade. So you can see in the light blue, 65% low grade CRS of grade 1 or grade 2, and only a small number of patients were at grade 3. All these studies were done in the COVID-19 pandemic era, and so there are COVID-19 events are high, and then some of the other side effects are listed over here. So why not combine bispecific antibody with lenalidomide, since monoclonal antibodies like rituximab and obinutuzumab have such good activity with lenalidomide. So in this study, which was recently presented again, showed very high response rates, 96% response rate with 84% complete response rate when epcoritamab was combined with lenalidomide, and the median duration of response was not reached, although the follow-up is short. So again, going back to the same theme that, okay, we're going to look at future directions and with bispecific antibodies, so plus lenalidomide, what are the future directions? Mosunetuzumab and lenalidomide are being combined. I didn't show you the data of mos and len, but it has very good activity as well, similar to epcoritamab and lenalidomide. And that is being compared to rituximab and lenalidomide, where we already have data as a baseline from the AUGMENT study in relapsed refractory follicular lymphoma. So the goal is to see if we can improve progression-free survival by adding a bispecific antibody with lenalidomide compared to our standard monoclonal antibodies with lenalidomide. And similarly, epcoritamab is also doing, there's a study with epcoritamab plus lenalidomide being compared to rituximab and lenalidomide. And this is also, being studied with PFS as an endpoint. So now moving from bispecific antibodies to CAR T-cell therapy, and just starting with axi-cel, the ZUMA-5 study has long-term follow-up now. This is a CD19 CAR T-cell therapy, which has been approved in follicular lymphoma. And the long-term outcomes are now available. You can see duration of response. The median duration of response in follicular lymphoma is high at 55 months. And the median progression-free survival is also 57 months. So these are really excellent outcomes in a heavily pretreated population. Another unique thing which was done with this study is looking at lymphoma-specific progression-free survival and lymphoma-specific survival, because there are also competing causes of death, natural causes of death, and things like that. So one of the goals in follicular lymphoma, as we are evolving with the treatments, is to identify if we can avoid lymphoma-specific mortality. And so that is sort of looked up, and in terms of that, on the ZUMA-5 study, disease progression or death due to study treatment at 48 months, that was 33%, and disease and in terms of overall survival, it was 15%. And in terms of competing risk, it was also 15%. So here, the investigators are trying to separate the overall survival and PFS related to lymphoma or unrelated to lymphoma and its treatment. And then in terms of safety, axi-cel does have a higher CRS. So what you see over here is in terms of any grade 3 effects, you can see that 78% of patients had any grade CRS, and but grade 3 CRS was only 6%. Neurologic events, 56% overall versus 15% grade 3. But importantly, very important to remember, when you look at the last row, patients with resolved events, 99% and 96% in terms of CRS and neurologic events were resolved. So we have now learned very well how to manage CRS and neurologic events. I'm not saying everybody recovers, but most patients will recover with excellent treatments which are now available for treating these. Moving on to Tissa-cel, another CD19 CAR T cell therapy with 4-1BB background, different from axi-cel. And this was also studied in follicular lymphoma. What you can see over here, the median PFS was about 3 years. The median overall survival is not reached. When you look at that POD24, the high-risk group, the median PFS is 30.8 months. The median is not reached if patients had not achieved POD24, meaning if they were not early progressors. So yes, it did have good outcomes in POD24, but the outcomes were worse than those who were not in that POD24 group. So overall survival, there was no difference between the two, but the follow-up is still not very long. In terms of follicular lymphoma, we do need longer follow-ups. Overall survival was really good with this at 83% and 80% in those two groups. In terms of CRS and neurologic toxicity, what you see with Tissa-cel is the CRS rate is lower, and there were no grade 3 or higher events. This may be related to the different backbone which it has compared to axi-cel, and then ICANS was also very low with this drug. Rarely, there was one patient who did achieve have hemophagocytic syndrome, and then other all grade serious neurologic events were 8% and 2% were greater than grade 3. So the next one, which I wanted to quickly go over, is Lysocell. This is the third and last CAR T, which I'll talk about in relapsed refractory follicular lymphoma. And again, has very good outcomes, as I'll show you in the subsequent slide. But one difference over here is that Lysocell was also studied in second-line follicular lymphoma, small cohort of 23 patients, but very interesting data. So very effective in second line, 96% patients achieved a complete response. And in third line plus, 94% patients achieved a complete response. So really phenomenal, outcomes with Lysocell in follicular lymphoma. And you can see, although the follow-up is not very long, only 12-month follow-up, that progression-free survival median is not reached, and 91% patients are still free of progression in second line, and 80% are free of progression third line and beyond. Side effects, again, are with Lysocell, also using a 4-1BB backbone. Our CRS is not very high. Half the patients had CRS, but again, majority were grade 1, a few grade 2, and neurologic side effects were also not very high. Along those lines, use of tocilizumab and corticosteroids are not really high with Lysocell either. So future directions for CAR T, dual antigen target CAR Ts are coming. So CD19, CD20 CAR Ts. There are at least 2 or more products. I've just highlighted 2. And then allogenic CAR Ts are also coming, and this would be great because these are off the shelf, and we are getting very good with this genetic engineering. PD-1 knockout is also being introduced to further enhance the T-cell response. So a lot of good gene editing occurring, and of course these CAR Ts are gene modified so that it doesn't stimulate graft versus host disease. Lastly, tazemetostat, which is an EZH2 inhibitor. has activity in follicular lymphoma. The response rates are not that high, and the median duration of response is at a year. Little more than that if EZH2 is mutated, and slightly lower than a year if EZH2 is wild type, but certainly an option available. This drug has very few side effects, so it's very well tolerated. So an option, but in terms of future directions, you're looking at tazemetostat in combination with rituximab lenalidomide versus just rituximab lenalidomide. Looks like this backbone is something which has been very much utilized in future clinical trials. As I showed you, similar things with mosunetuzumab and epcoritamab and other treatments, comparing rituximab plus lenalidomide in the control arm. And tazemetostat actually also is being combined with CAR T, where patients actually get tazemetostat started. This is a clinical trial at the University of Pennsylvania. Or I believe I think I said that incorrectly. Perhaps I think it is at Cornell, and started 1 week before apheresis and continued for 6 months after CAR T in patients with CR and 12 months for patients with PR. So that brings us towards the concluding remarks. We need to be able to choose wisely in relapsed refractory follicular lymphoma. So the first question may be relapse with follicular lymphoma, or is it transformed disease? I think this is very important to know because the treatments are going to be different often. And the expectations of what to expect from the treatment may also be different. Is it an early relapse or late relapse? What previous lines of therapy have been used? Comorbidities and performance status of the patient, so patient characteristics. Are we planning to do a time-limited therapy, or is this going to be an indefinite treatment till progression or intolerable side effects? Those are discussions we should have with our patients. Talk about the ease of administration, an oral drug, parenteral drug, even in parenteral subcutaneous versus IV. Need for hospitalization. I forgot to mention earlier that mosunetuzumab does not have any need for hospitalization when it is administered, and access to therapy and cost. Those are all things to think about when we are trying to decide which treatment to choose from in relapsed refractory follicular lymphoma. So my final slide is leaving you with some final thoughts. What is the most desired goal of treatment? So, of course, we want our patients to live as long as possible. Can we avoid lymphoma-related mortality, either from the lymphoma itself or from the related to the treatment from lymphoma? So that may be a goal. Can we think about something like functional cure? That's another, certainly a thought. Are our goals going to be different based on the age of presentation? So what about those about 25% of patients may be younger, even in their 40s or younger, and their goals of treatment, they may be looking at 40-year survival, not at 5-year, 10-year, or 15 years. So how are we going to achieve that? So should we treat our younger patients differently, or should our approach for younger patients be different compared to somebody who is already in their 70s or 80s, or even in their 90s with follicular lymphoma? And then, is PFS benefit enough as an endpoint? We have seen that obinutuzumab is better than rituximab. Is that become common practice? Perhaps not universally. So do we need to look at also safety? So is it going to be a good balance between efficacy and safety? Is what will need to move the needle. And then CAR T cell therapy can result in very high durable responses. I showed you data from 3 clinical trials with axi-cel, lysocell, and tisa-cel. But what we need is improved tolerability, improved access to have a larger impact in follicular lymphoma. And then bispecific antibodies are readily available off the shelf and result in high durable responses. Unfortunately, some of the side effects, CRS and neurotoxicity, have come down from CAR T cell therapy, but they are different. And a recent publication in Blood goes over how to deal with toxicities from bispecifics. It's mostly low-grade CRS. The use of tocilizumab and steroids are quite low, and neurologic events are extremely low compared to CAR T-cell therapy. So understanding those differences, and then also I hope I've shown you that or convinced you that bispecific antibodies are moving in a big way from relapse refractory into the frontline setting, at least in clinical trials. So I want to thank you again for your attention. I'd be happy to take any questions. So I see one question which has come through the chat is how does treating follicular lymphoma uh, relapsing transform to DLBCL, how it differs from de novo DLBCL treatment. So that's a really good question. It differs in the way that in de novo DLBCL treatment, we usually use anthracycline-based backbones, whether it is CHOP or polar R-CHOP or polar CHP, or in selected cases R-EPOC. But in follicular lymphoma, which has transformed, we will first have to see what they were treated with previously. If they have already received R-CHOP as their frontline treatment, then the second line treatment is going to be unlikely going to be another anthracycline based, because 6 cycles of anthracycline based therapy would have probably been used in frontline, which would not be the case in de novo DLBCL treatment. So if they have not, I think anthracycline based treatment would be the first line in transformed follicular lymphoma as well. So hopefully that answers your question. In another question which has come through is, in POD24, what is the preferred treatment? And if to choose autologous transplant. So we don't know yet what is the preferred treatment with POD24. The clinical trial, which I showed you comparing lenalidomide-based approach with chemotherapy-based approach, and it also will have some patients who got PI3 kinase delta inhibitors, although that arm is not accruing, might help us to decide what would be the most favored treatment. So, at this point in time, I think clinical trials, incorporation of bispecific antibodies, if possible, CAR T-cell therapy, lenalidomide is, certainly a really good second-line option. So for POD24 patients as well, I think outside of a clinical trial, a lenalidomide-based combination, in my opinion, would be a good standard option if chemotherapy has already been exhausted as a frontline option. So, that would be another thing. Let's see if there are any other questions. In which patient do you indicate autologous transplant is another question which came through the chat. That the role of autologous transplant has been diminishing. In POD24 patients, autologous transplant was being used on the clinical trial. They did allow patients on that study which I discussed, they did allow patients to go to transplant after their second line treatment if they were chemosensitive. The number of patients getting autologous transplant for follicular lymphoma is going down, especially as immunotherapy approaches like CAR T-cell therapy and bispecific antibodies are making their ways into relapse refractory treatments. That's sort of the current trend. All right. So thank you so much again for your attention. Have a great day. Bye-bye.